Today, we will be discussing one of the commonest causes of testicular pain in young males, as well as probably the commonest cause of male infertility, and how, even till date, it is unfortunately being treated by these tools, of course, the medical variants of these, when it doesn't need to be anymore. Now that the dramatic hook is out of place, let's talk about varicocele, the condition we are going to cover today. Varicocele is a male testes condition usually affecting common males 15 to 35, and it has something to do with the blood supply of the testes. You see, the blood supply of the testes is via arteries, meaning the heart sends pure blood to the testicles via arteries, testicular or spermatic arteries. Once the oxygen, the nutrients are given to the testes, the blood returns back, and mind you, this is impure blood full of toxins that returns back to the heart via simple vessels known as veins, the testicular veins or spermatic veins. Now the veins have to carry blood against gravity almost all of the day that you are standing or sitting without any major pump helping it in the process, which potentially and naturally leads to a condition where the blood would tend to pool down, especially if you are standing or sitting for a major part of the day. To prevent this, naturally, there are valves or one-way doors in the veins all throughout the course so that they allow the blood to pump up or travel towards the heart, but do not allow the downward pooling of blood or a reverse flow of the blood. But there is a common condition where, due to various reasons, inflammation, ergonomics, injury, these valves can get damaged. And when they do, they become bidirectional valves instead of unidirectional ones. And they allow blood to pool down towards the testes, into and around the testes, and start harming the testes. You see, pooling of blood towards the testes causes rise of temperature within the testes or within the scrotal sac, and that harms the testes. The testes always require a cool temperature, at least 2 to 4 degrees lower than your core body temperature. That is why naturally they have been placed outside into the scrotal sacs. But this pooling of blood raises that temperature. Also, the free radical damage that occurs because of the blood pooling and again impure blood pooling causes secondary damage to the testes. Because of these two conditions, we see a myriad of features and symptoms and signs that start occurring as a cascade. First, the commonest thing that we notice is testicular pain. Yes, young males come to us with severe pain and with severe constant pain, with heaviness and moderate to sometimes severe constant pain, aggravated by prolonged sitting or standing and relieved by lying down or raising your legs on a surface. The second commonest sign or symptom they notice is a bag of worms or a bunch of worms beneath the skin near the testes or above the testes. This is a very common Aunt Minnie sign, and many testicular varicocele patients come to us with this sign that, doctor, I feel as if there are worms crawling underneath the skin, but they are actually veins where the blood is reversing, and that is what you are misinterpreting as worms or parasites. The third common reason why these patients present to us is because the varicocele is harming their semen production. See, testes produces sperm and it produces testosterone levels, and both of these functions can get harmed because of the free radical damage and the high temperature. So yes, male infertility is one of the commonest presentations of this condition. In fact, varicocele is probably arguably the commonest cause of male infertility. Low testosterone has also been seen in varicocele patients, especially after a certain age and after a certain damage. They also come to us in advanced stages with testicular shrinkage, where because of not treating the varicocele neither by lifestyle nor by a surgery or embolization, we will talk about these later, the testes have already started shrinking in advanced stages. There are cases where because of bilateral shrinkage, low testosterone, we have seen erectile dysfunction or sexual issues in these patients. And finally, small bunch of patients or sometimes a significant bunch of patients come to us because they are defense aspirants trying to enter the armed forces or police academies, and the varicocele has caused rejection in the physical examination, because during physical examination, if a patient is found to have this condition, they are outright rejected because the authorities worry that if it's untreated, then you are investing millions of dollars into training the candidate and he may not prove to be an asset for the country, potentially harming national security. So that is one more reason why candidates come to us for treating this, so that they can get selected and fulfill their dreams of serving the nation. Now that you have understood what varicocele is and how it can commonly present, what to do if you have one or more of these signs that we discussed, which I am listing in front of you, what is the next step? The next step is you meet one of the two specialists, either a urologist or an interventional radiologist. And I'll tell you why I'm talking about interventional radiologists here very soon. So stay tuned. We are going to in detail talk about why I am saying that surgery is not the gold standard anymore, or at least shouldn't be the gold standard anymore, and we'll discuss about this, so stay tuned till the end. Well, like I said, you visit a specialist amongst the two. Once you go there, they will physically examine you. They will potentially do or get done a scrotal Doppler, a color sonography of the testes, where your testes will be checked on ultrasound, both in the lying down and standing positions. First at a relaxed position, but then after a provocative maneuver known as Valsalva maneuver, where they might ask you to hold your breath and apply internal pressure as if you're passing stool or straining to pass stool, and that pressure aggravates the varicocele and you can catch even the subtle grades or provoke the high grades to even a higher diameter and confirm the grade. Based on the Doppler, which is one of the starting as well as gold standard investigations, we give you a Certeschi grade between 1 to 5, 1 being the mildest variant and 5 being the worst. Then we can plan further. Of course, with this we will test whether till date your testicular functions are affected by doing a semen analysis and a testosterone level, both the free and total testosterone level. And based on all this information, then we are in a good position to guide you and treat you. If your varicocele is early grade, we don't see any testicular shrinkage, semen analysis shows normal sperm morphology, motility count, your testosterone levels are normal, and you do not have refractory pain despite lifestyle changes, we might give you a bunch of lifestyle changes, which is a topic for another video. If you comment lifestyle in the comment section, I will give you a detailed lifestyle video very soon on what can potentially halt the progression of varicocele or even potentially cure it in a very few selected candidates. But if it's high grade and there are one of the red flags that we mentioned, your testes are already shrunk, or you have grade 4 or 5 varicocele, you have a lot of testicular pain refractory to lifestyle changes despite trying for a few months, your testosterone levels are low, your semen is affected, you have ED or secondary issues, then I would say it's better to treat the varicocele with surgery or embolization rather than just focusing on lifestyle and potentially causing a delay. Now, coming to the most controversial point of the day, what is the gold standard or what is the preferred modality of treatment and what should be the preferred modality of treatment? Now, the principles of treatment lie on destroying the vein or the reversal of flow by completely ligating or cutting the main vein. Yes, because you know the valves are damaged, till date there is no technology to repair the valves. It's under development and research, but it would take a few decades before it gets commercially available if it gets approved by FDA and other agencies. So that's why let's discuss the standard treatments available today. If surgery is considered, there are 3 ways of treating it, but the primary method is you either take in a suture and you ligate or completely tie off the vein so that reversal stops. Now, it makes sense to stop the reversal of blood, but how does the blood return back to the heart? That is a question which most of you have, a valid question, and it returns via collateral naturally existing bypass channels known as external spermatic veins, gubernacular veins, deferential veins, and many more. So tying it off or cutting it off is not a problem. And as you rightly heard, the next natural method is using a scalpel or a scissor and cutting off the varicocele, the vein that's damaged, the internal spermatic vein, so that there is no reversal. Now, either of these methods are very effective. They can be done by 3 routes, either a open surgical route, which was the traditional route, or a laparoscopic one, which was a minimally invasive attempt to ligate or cut off the same veins. But to my experience and what I've seen with my peers, usually it miserably fails because you do that at a very high level, and because of that there is recurrence and the veins recur because of collaterals at a much lower level. So I won't say varicocele is the top model of treatment today, although surgical expertise, ways of doing it may differ. A person who has a high volume experience might do a laparoscopic approach also very well, but usually not considered the best. The gold standard method of surgery today, whether you want to ligate or cut, is something known as microsurgical ligation. Yes, in this method you take a microscope, you give a very tiny incision subinguinal, a level pretty below your groin but just above your testes, and you tie off most of the veins or cut most of the veins which are causing reflux of blood towards the testes rather than taking blood from the testes to the heart. And once you do this, again the blood reroutes through natural channels and usually there's no harm. Textbook picture or article picture, this is the gold standard till date. The recurrence rate is between 1 to 9%, not 0 mind you. Complication rate is relatively low, but yes, there are genuine chances of hydrocele because they end up tying the lymphatic channels also, which reduces the lymph outflow from the testes and causes hydrocele or fluid accumulation in the covering of the testes, which in its own can cause some problems which need treatment. There can be infection and rare cases but a most morbid complication if a surgeon is not experienced enough, or despite experience enough, he may mistakenly inadvertently tie the artery which is supplying the testes. That can lead to a major damage to the testes and potential ischemia or death of the testis tissue. And a fourth concern is of course recurrence. In best of hands, the failure and or the recurrence rates are between 1 to 9%, not 0, and that is also a concern. So why is microsurgical ligation the gold standard today, and isn't there any alternative to this surgical method which can equal it or even challenge it for the throne? Well friends, I am here exactly for that. As an interventional radiologist, we have brought up this controversy many points of time, but let's break the barrier and talk about now a minimally invasive option which can treat the same varicocele without any blade, without any sutures and without any scar. This method, this novel minimally invasive method but yet established method, is known as varicocele embolization. Let me talk first about this procedure and then tell you how it is advantageous over surgery and why it's still not the gold standard. We will definitely come to that controversy. Varicocele embolization is a method by which an interventional radiologist can enter your groin or your neck or sometimes your arm and take a tiny catheter and park it into the vessels which are going towards the testes or carrying blood away from it. So once I enter, so my preferred choice is the groin vein, the thigh vein. I take a tiny catheter through that, which is 5 French or 4 French, around 1.1 millimeters in diameter. I take it across and park it into one of the main veins, which is the outflow veins. And finally, I take a micro catheter, which is 0.4 millimeters diameter, 1.98 French, into the testes vein, right deep, almost just above the testes. And I inject a few liquid agents to prevent recurrence as well as to completely occlude the vein from within. In this method, I do not need to ligate or cut the vein from outside. I can sort of do a endoluminal ligation, meaning inside the vein, through the vein lumen, inject a agent which can occlude the vein completely. Yes, I am doing this under X-ray guidance, also known as fluoroscopic guidance, so that I do a venography first, a dye injection to confirm whatever channels are causing the varicocele and knock off each channel without causing the least possible chance of recurrence. Once I finish the procedure, once I ligate the whole vein, my preferred agent is glue. People use coils and cetrol or sclerosants and a lot more. But yes, once the procedure is done, you remove all of the hardware, you remove the sheath that you worked from in the thigh, you give a gentle pressure there for 10 minutes, the patient lies down in the ward for maybe 2 hours, and then the patient is free to walk and potentially get discharged in the further next couple of hours. That minimally invasive a technique. Now let's discuss a few advantages of this technique. Advantage number 1, it's done under local anesthesia. The patient is wide awake. All my patients look at the screen, the angiographic screen, fluoroscopic screen, and see the procedure being done live into their bodies. They have no pain or sensation whatsoever. There are a few steps like the initial local anesthesia which can cause a minor sting like a vaccine injection, or the glue injection which can lead to a small inflammatory pain which is very transient for a few minutes, couple of minutes, but other than that it is completely painless and sensationless. So the procedure is done wide awake under local anesthesia, no need for sedation, spinal anesthesia or general anesthesia. The procedure is done on a daycare basis. You can go home after 6 to 8 hours of admission. No further admission required without any major exception. Unless there is some kind of allergic reaction or issue, there is no admission required. The procedure is done without any blade. It's minimally invasive. There are no sutures used and there is no scar, so cosmetically it is very patient friendly. After 7 days, there is not a single patient amongst my last 1100 patients who has ever been able to tell me where the procedure was done from. It is actually practically scarless, no hidden ulterior changes here. The procedure is conducted under fluoroscopic vision with venography or injecting a dye, so potential of missing channels for recurrence reduces. Microsurgical ligation, although gold standard, there are variations, there are issues, and sometimes you miss channels. That is why, although the urology guidelines say that microsurgical ligation is gold standard, when you ask them what if the microsurgical ligation embolization fails, then they say yes, then embolization is the gold standard or the number one approach, which most urologists unanimously agree. That raises a doubt, right? But anyways, coming back to the advantages, the further advantages are the recovery period is absolutely zero. Next morning onwards, the candidate can start his studies or work, profession, whatever he is involved in at that point of time. Unlike surgery where there is a recovery period of 2 weeks, some restrictions for 2 to 3 months, there are only simple restrictions for a week which include no ejaculation, no intense weightlifting and no high intensity workout. Other than that, no major restrictions here beyond a week. And the list of advantages go on. There is no chances of hydrocele because, even in studies, it's proven to be nearly zero because you're not tying off the lymphatics. In fact, you are within the vein, so you cannot tie off the lymphatics even if you want to. Same with the artery, although rare in surgery also, but zero here because you are endoluminal. You are within the vein, you can never tie off the artery even if you want to. So, huge chances of infection, bleeding, or any other major complication. The scar tissue causing neural pain and severe neuropathy and pain for months, all that is negligible or zero here. So with those many advantages, why is varicocele embolization still not the gold standard or still not at least a decent competitor to surgery? Let's straight jump to the elephant in the room and answer this controversial question. First, microsurgical ligation is the gold standard not because of randomized trials comparing microsurgical ligation with embolization. There is no data, no randomized trial comparing the two for various reasons, but because of traditional authoritative referral pattern. Yes, traditionally each and every male patient knows that if you have testes pain, if you have varicocele, you have to go to a urologist. Urologists have been doing this older technique from decades, evolving it in the form of laparoscopies and then microsurgical ligations, modified ligations with testicular delivery and external spermatic gubernacular ligations and varicocelectomy. And that's why we have no dearth of data. We have hundreds and thousands of patients published with decent amount of data. Many of the urologists, because urologists are the primary referral pattern there, in most hospitals they have high volume experience ranging between 500 to 1000 patients, so there's an upper hand there in terms of skill set. Despite all of that, there are failures, there are recurrences, there are complications we spoke about, but yes, that was believed to be the best possible thing a surgeon can do after getting a high volume expertise and skill set. Urology societies are known, unfortunately, but at the same time that's the truth, to not accept these novel minimally invasive procedures despite data coming in, springing in, because of inertia, because of guideline inertia, which takes time to change. Most of the guideline formation societies or even experts are urologists. That's also a reason. We have seen how prostate embolization has keep putting data and randomized control trials, meta-analysis, and still it took decades before prostate embolization has been accepted in the American Urological Association Society as one of the treatment options for treatment of BPH or benign prostatic hyperplasia. Same is the case with varicocele. It might take a few decades before the societies have no choice but to choose it as a valid alternative. But if you see meta-analysis, if you see systematic reviews, if you see data springing in now, standard journals like CVIR, JVIR, you will realize that even the published data for varicocele embolization is now gaining grounds. Patients are getting more aware and wanting to choose these alternatives and directly going to interventional radiologists. Now, one thing I want to highlight is most urological societies or even urologists personally, anecdotally, if they have a operated case who is presenting with recurrence or failure, they would be happy sending the patient for embolization because they know that doing a repeat microsurgical ligation may not be the best thing. And because embolization has the advantage of angiography and we can go in and do a check angiogram, see what channels were missed, embolize them, that is probably the gold standard officially and unofficially. I don't think urologists will argue against that. And that is where I want to question, if a surgical ligation fails, you are telling me embolization is the best. But for a new patient who comes first to the urologist, embolization is not good enough. That doesn't make sense. So again, we have spoke a few things about why microsurgical ligation is still the gold standard on paper. Now, what about embolization? Why is it still not popular if it has so many advantages that we listed and that I'm showing you here? Well, one primary reason is the referral pattern again, where patients are coming to the urologist, so only failed cases, complex cases, cases on blood thinners, they are sent to interventional radiologists and not many. Most interventional radiologists, because of this referral pattern and not having a direct B2C approach or radiologist to customer approach, do not have high volume experiences, and because of that, yes, skill sets in embolization also vary a lot. Unlike surgery where urologists uniformly get to do high volume cases during their training training, during their post-training life, interventional radiologists may not do the same number of cases. In fact, I know many peers across the country, across the globe, who have done maybe 6 cases on an average in a year or even lesser. And that's why the expertise, the skill set, the evolution of hardware, embolic agents is not good enough now. The SOPs are not standard enough now. And that is where there is some disadvantage there. But while this should be highlighted by our urology peers, they end up talking about, many of them, and of course I respect urologists a lot, but many of the urologists end up talking about gimmicky stuff like your embolization procedure may cause radiation damage and harm the testes, the coils they are injecting may fly off to the heart and cause a major heart attack. They are using contrast or dye for angiographies and that may harm your kidneys. Well, all this is, to be honest, crap and bullshit, and this is lies. Urologists know that, and the small amount of dye that is being used is much less even than a heart angiography procedure. It would cause zero harm to a patient with normal kidneys. Any nephrology guideline, any nephrology society, any nephrologist can vouch for this, so don't worry about your kidneys. The radiation, on an average, if you see my radiation dosing after my varicocele procedures, even bilateral, sometimes it ranges between 27 to 67 milligram. Most of the time, sorry, not sometimes. And that is why don't be concerned about that. That is a very minimal dosage, maybe to the accountability of 4 international flights. And I don't even use coils, which sometimes causes, yes, pain and granulation tissue. Forget about coils flying off and so on. I don't think good interventional radiologists may cause that kind of a complication. Even low volume varicocele centers would not do that. But yes, let's even forget about that. I or many of us don't even use coils. So point is, let's not focus on these gimmicky stuff or this bunch of lies. Let's focus on actual problem, which is, yes, lack of volume, lack of skill set, lack of evolution of SOPs, which does lead to slightly higher recurrence than surgery, but still it is minimally invasive and lesser complications. Good thing is, even if there is recurrence, still the surgical option is on table. You can always go and do it. Even the embolization procedure can be repeated by a second operator, and most of the times you end up getting the failure reason and you can embolize that and treat it. So with that, with so much synopsis and so much discussion about controversies and details, I would urge all of you, anyone with varicocele, whether it is causing pain, whether it is causing infertility, or whether you want to get selected in the armed forces and have been rejected because of this, approach a urologist. Yes, I'm not asking you to skip that part, but approach an interventional radiologist, understand that particular interventional radiologist skill set, experience, the SOPs that they follow, and then decide which procedure you would want to choose. There are a sizable number of you with the right selection who can get interventional radiological treatment done. Varicocele embolization, which we showed you. Mind you, it was always believed that varicocele embolization is meant for left varicoceles, but today we can do it equally well for bilateral or right varicoceles, and I don't remember the last case where I failed just because of a right varicocele anatomy. That has changed with skill set again. We ourselves in the past, because of our social media presence, direct patient awareness campaigns, have reached out to 1100 patients whom we have personally operated. Maybe 10 times more number of patients have been guided for lifestyle changes and not operated unnecessarily or embolized unnecessarily, who are on the path of recovery, or at least the process has slowed down. And with this, I'm proudly saying that yes, we are one of the highest global centers to do varicocele embolization. With this, I would like to urge you to again comment lifestyle if you want to know more lifestyle changes, and if you have any other particular query, or if you do not have an interventional radiologist around with this kind of experience, you still want to approach us. I'm dropping my number here, and you can in the comment section tell me what you're facing. Very soon we can connect also. I'm specially making this English video and this English channel for my international patients who sometimes do not have good referral pattern around, and you are most welcome to reach out to us and discuss with us. Stay safe, stay empowered.